Recording in progress. Yeah, good evening, Pankaj Bhai and Hiren. We just wait for Ganesh to join and Mahendra.
Sure.
It was Ganesh will
Yes, sir.
join.
Good evening, sir.
Good evening. Just 1 or 2 minutes he's joining, and then we start.
Sir, who will be answering today, sir?
Who is answering today?
Sir, Dr. Tanmay and
Sir,
and Ajinkya and Dr. Miraj will be answering today, sir.
Tanmay, Ajinkya, and Miraj.
Yes, sir.
Yes, sir.
Okay.
Sir, good evening. Mahendra here.
Mahendra. First, I was trying you only.
Yes, sir.
So just I'm waiting for 1 minute. Once Ganesh joins, we start it.
Join.
Yes, sir.
Yeah, Ganesh has joined.
Yes, sir. Good evening, everyone.
Yeah, good evening.
Good evening, Mahendra bhai and Ganesh bhai.
Good evening, Hiren bhai. कैसे हो आप? Good evening, Pankaj sir.
Good evening, everyone.
Dr. Gite is busy in a meeting, so he will join after 15-20 minutes.
Yeah, I have joined.
There is a mock exam, going to be held by USI. I think on 24th, 25th. Pankaj must be knowing it better.
Yes, I think it is there this weekend.
This 21st, 22nd. Okay. So they have got a meeting. So they will. He said that he will join by 9:30. So I think we should start now. We have got basically 3 different cases of RCC. So let us see, because all the 3 cases are such that even we need to know what is to be done in this case. So all your inputs will be very helpful to us.
Really credit to you, Gaurang bhai. आप इतनी मेहनत करके इतनी cases जमा करते हो.
Luckily, what is happening? We decide the topic, and in OPD or in hospital, the patients are getting admitted.
अरे सर, patient लाना इतना easy है तो मैं अभी next second decide कर देता हूँ.
But surprisingly, we are getting sometimes some good cases. So today also we have got really 3 good cases. Ganesh and Mahendra will be really excited.
Yeah.
And Ganesh, Mahendra, and even Maheshwari, I have already told you to please for our indoor this thing, conference, I want your input.
Certainly, sir, anytime, whatever you want.
Yeah. I already put it on a group, but then personally we will meet and in 1 or 2 days, and we should,
Anytime.
finalize. Okay, fine then. Let's start.
So I will present the first case scenario.
Good evening.
A 50-year female resident of Mumbai presented to our side with complaint of pain over right flank for last 3 months. There is a background noise somewhere.
Ajinkya, what are the important questions you want to ask?
Something like war is going on.
Swastik, just show the first slide.
Sir. Sir, 1 second, sir.
Yeah. Ajinkya,
Hello?
this is the history.
Hello? Yes, sir.
Now,
So I like to ask the onset, duration, and progress of the complaint. Then, is there any aggravating or does this pain relieve on any medication? Then I'll also like to add on certain. I'd like to ask any history of associated fever, then any history of hematuria associated with it, any history of lithuria, hematuria, fever, then
So Tanvi, what are the differential, normally whenever you get such a history, what are the differential diagnoses that come into your mind?
So first differential that would come to my mind would be stone disease, sir. Just 3 months of pain. If then other causes of pain might be renal cystic disease. PUGO in this stage is very unlikely, but as a lower down I'd like to keep, and a renal mass would be my last diagnosis. TB would be another differential I'd like to keep, depending on whether or not LUTS is there in the negatives.
Only urological, nothing else in the right flank?
Yeah, right flank. Yeah, if I go for more wide differential diagnosis, I would like to consider cholecystitis, pancreatitis, any hepatic mass, or right-sided colonic masses.
So why it is if? Why not you have everything like in number 1, 2, 3, 4, 5, this, why if word is there? So sir, simple ask, patient having right flank pain for last 3 months. So definitely everything, every organ which lies on the right side or abdomen may give. This is because right flank, but he did not ask posterior, lateral, like that, a specific site. Okay, below the ribs. Only then you can specify something like 1, 2, 3, 4. If it is only right flank pain, definitely your kidney will be the first organ which may lead to this right flank pain. But again, we should not miss the other organs. Okay.
Okay. Fine. Swastik, go ahead.
Yes, sir. Patient is apparently symptomatic 3 months back. When she started developing pain over right flank, pain was dull aching in nature, non-colicky, insidious in onset, gradually progressing, non-radiating. No specific aggravating factors were there, and really not taking analgesics.
Yeah, go ahead.
Coming to negative history, there was no history of burning micturition, no history of fever associated with onset of pain. There was no history of vomiting, no history of hematuria or lithuria, no history of increase or decrease in frequency of urination, no history of facial puffing, congestional breathlessness, lower limb edema, no history of jaundice, and all of it. There are no comorbidities in the patient. Family history is non-contributory. Personal patient consumes a mixed diet. Appetite is normal, bowel regular, bladder normal, is normal, non-alcoholic, non-smoker, and non-tobacco chewer.
So Mera, only one question in family history. Why is there any significance in family history in urogenital cases? Any?
The BHL syndrome is there, which can be familial, and tuberous sclerosis can be familial. And similarly, we have birth tube dubate syndrome. And if the patient is having less than these tumors are less than 45 years of age, and multiple are there and bilateral is there, then it will be then the family history will be positive.
Ajinkya or Tanmay, can you just elaborate any relationship when we say family history, any urological, urogenital correlations?
It can be two things, sir. Firstly, when it comes to benign causes, urolithiasis might have metabolic diseases that run in families, like oxaluria. Then other one cause I would like to elaborate will be box contact for GUTV, and lastly the familial RCC syndromes and Lynch syndrome for transitional cell carcinomas.
Okay. So which are the syndromes? Can you just elaborate the syndromes?
In familial RCC, there is a VHL syndrome, sir. That is von Hippel-Lindau syndrome, which consists of retinal hemangiomas with renal cysts, pancreatic cysts, cerebral hemangiomas, and that is divided into type 1 and type 2. Then other is hereditary leiomyomatosis RCC syndrome, HL-RCC syndrome. Then there is hereditary papillary RCC syndrome, Cowden syndrome that is associated with P10 gene, Birthoff-Dube syndrome, and tuberous sclerosis.
And apart from kidney,
Apart from the Lynch syndrome with the transitional cell carcinoma, sir.
and for the prostate,
So sir's question was genitourinary syndrome. So you should tell everything: kidney, ureter, bladder, prostate, testes.
Prostate, I don't know, sir. Sorry.
Ajinkya or Miraj? Yes, BRCA.
Oh, yes, yeah.
See, all the idea of asking you this question again and again is every time so that everyone remembers all this syndrome. So in exam, you don't forget. Okay, Swastik, go ahead.
The general examination, patient was conscious, cooperative, well oriented to time, place, and person. Pulse rate was 70 beats per minute. BP was 130 by 80 millimeter of mercury. Respirator 18 per minute. Febrile. Saturation 98% of room air. There was no evidence of pallor, icterus, sinus clubbing, lymphadenopathy, or edema. Spine examination from head to toe was normal. Karnofsky score was 90. Per abdomen examination, patient examined in supine position with implied informed consent with exposure of communicating to inadequate dim light. On inspection, lateral century place, all coordinates were moving including respiration, no scars, sinuses or involved veins were seen. On palpation, there was no localizer temperature, there was no tenderness, bladder was not non-palpable, and there was no renal angle tenderness. On percussion, tympanic note present all over the abdomen, normal liver wellness scan was there. Auscultation, normal bowel sounds were present. Rectal examination was done in Singh's position. There was no evidence of fissure, fistula, or hemorrhoids. Anal tube was normal, and there was no blood on the gloves.
So this is a
yes, sir.
No. This is a okay. You finish it.
Yes, sir. Respiratory system, air entry bilateral equal. Cardiovascular system, S1, S2 were normal. There was no murmur, and CNS examination was normal.
So next, what?
Examination findings are all normal, sir. The vitals are stable with good Karnofsky score. So I'd like to go with a routine blood tests like CBC and renal function tests along with urine routine and followed by a ultrasound of KV, abdomen, because my differentials are not restricted to
Yeah, Swastik, just show him whatever
Yes,
he has asked.
yes, sir. We went ahead with the blood investigations, and hemoglobin was 14.6 gram per deciliter. Total leukocyte count was 6,480, and platelet count was 2,24,000. Serum creatinine was 1.17 in this patient. And we also did a urine routine examination in which red blood cells is 0.6 per high power field and pus cells is 0.2 per high power field. Urine protein and ketones are absent.
And ultrasonography?
Sir, ultrasonography, the film is not available with us, but the report was like right kidney was showing a heterogeneous mass lesion on upper pole of a size around 3.6 into 2.8 centimeter with areas of necrosis. Left kidney was normal in shape and size and position. Corticomedullary differentiation maintained. Liver, spleen were normal, and there was no lymphadenopathy.
So 3.6 cross 2.8 centimeter upper pole renal mass with the which is heterogeneous in nature with areas of necrosis. I'd actually like further information from the USG, like the closeness to the pelvic calcium system is endo or exophytic, or vascularity of the mass, if any calcification was present, and how is the pelvic calcium system method dilated up.
Everything is normal. Whatever Tanvi has asked.
Sir, yes, sir. Grossly, sir, it was normal. The crux of the report was this only, sir. It was done outside, sir, not at our center. The report mentioned only this much of the findings, sir.
So now color Doppler is not done. You don't either you have to repeat the sonography or what else you want to do.
In this case, with a normal creatinine, sir, I'd like to proceed with a triple phase contrast and CT scan of abdominal pelvis.
So what is this as per the CT USG finding? What do you think? What is it?
The heterogeneous enhancing upper pole mass.
It is not enhancing. USG is no enhancing.
Yeah, sorry, heteroechoic. Heteroechoic mass with area of necrosis points more in favor of malignancy. Sir.
Okay.
So what other features USG can tell you?
About the whether it's a well-defined mass, whether it is near to the pelvic erectile system, sir, whether it's endophytic, exophytic, whether it's solid or cystic, whether there is presence of calcification, whether vascularity is good, the renal vein status we can come to know, any presence of liver mets or lymphadenopathy can be seen.
How will you see the vascularity of the mass?
With Doppler.
Color Doppler.
Color Doppler.
Okay.
So
what next? What do you want to do?
I'd like to go for a contrast enhanced CT of abdominal pelvis and a triple phase contrast.
Only abdo-pelvis?
Yes, sir.
And chest, because I'm suspecting malignancy in this case.
Okay, so you want to confirm with the abdo-pelvis scan, then you later on you want to do CT scan chest, or you want to do all the thorax abdo-pelvis in one go?
I'd like to do abdominal pelvis first, sir, because with the small mass, CT chest usually is not recommended, sir. Less than 4 centimeters, even X-ray chest is what we usually follow, sir.
So it is more specific, chest X-ray or CT?
CT chest definitely more specific.
Okay.
The chances of metastasis in a small mass are less. That's the
yeah, but you do not know the tumor grade.
Yes.
Right? It can be high grade also.
Yes.
Ab kya karoge? What you will do now?
USGs can tell you about angiomyolipoma.
It will be a hyper-enhancing mass, hyper-echoic mass because of the high fat content, usually without areas of necrosis.
Okay. So yours was heteroechoic. It is quite possible.
Yes, sir. So that's what I would like to confirm that it's a malignant mass, like gauge a better idea of it being a malignancy before subjecting the patient to a CT test.
So, on basis of vascularity alone, suppose you get the sonography report, what is shown, and I am the patient coming to you, CT not done. Are you going to say always malignancy?
No, sir. No, sir.
What is the chance of 3.6 centimeter mass being malignant?
Sir, 60%. Sir.
16 or 60? I didn't get that.
60, sir.
60%. 60. Okay, any reference for that? 60.
No,
there is
sir.
an article in Journal of Urology, Blute et al.
Okay.
So these are common questions you should know. Small renal mass, chance of being benign with all the features like this, necrosis and all, is 25 to 30%. Go ahead with the CT.
Yes, sir.
Can you enlarge the important images?
So it is. So actually, this is the largest I could fit in this. Zoom option is not available on this slideshow, sir.
Okay. Okay, so Tanmay, what do you want to see in the CT scan?
So firstly, I'd like to the mass that is there, sir. I'd like to know the features of the mass, its size, exact site, which was related to, whether it's endophytic or exophytic, whether it is involved in the
When I
contrast.
ask, sorry to interrupt you, when I ask what do you want to see the CT scan, that means I want you to describe the CT scan.
Okay,
That what things you would like to see in any CT images. And if they're renal mass, then what specific thing you would like to see in CT scan?
okay. So in a CT, first I'd like to see whether all solid organs and spine are normal. When it coming to the,
I would see first what areas are covered, and second I will see it is non-contrast or contrast, both.
Yes.
Okay, and then I will describe the next thing. The next thing.
Okay, sir. So it is a CT scan of abdomen and pelvis with plain and
lower
contrast.
thorax. See, you can see lower thorax, lower chest.
Yes, sir. Lower chest. Lower chest up to pelvis, sir. Then with the plain and nephrographic contrast phase, sir.
Simple, non-contrast, contrast.
Okay, sir. It's contrast, non-contrast with the plain and contrast phase. It's visible solid organs appear to be normal, sir. In the right kidney, there appears to be a posterior exophytic plus endophytic mass at the upper pole, with the areas of which is heterogeneously enhancing, with areas of central hypoenhancement suspected of necrosis, which is abutting the pelvic erectile system, sir, with no obvious lymphadenopathy, with the contralateral kidney appearing to be normal, sir.
What else you want to see in CT scan in case of renal mass?
I'd like to see the liver as well, sir. No nodules visible, apparent in the limbs, and in the visible cuts of the thorax as well.
Okay, so whenever you suspect malignancy in the imaging, you first want to do a staging of disease, right?
Yes.
And staging, what staging what is included in staging?
Staging, firstly, the size is included, sir. Then,
remember, it's a TNM staging. TNM.
Yes, sir, TNM staging.
So what is T?
T is tumor.
T is tumor.
Yes, sir.
So
Tumor.
first of all, you focus on the tumor.
Okay, sir.
Now you describe in tumor what do you want to see in case of renal mass.
Firstly, I'd like to see the size of the tumor, sir, which here appears to be around 2 x 2 centimeters. I cannot comment correctly on the.
You can see only two dimensions.
Yes, sir.
Okay?
Yes,
Third
sir.
you cannot measure, but approximately where the largest size you can see that we can measure. Okay, maybe 3 or 3 by 2 or 3 by 3 mass, right?
Yes, sir.
Size. Next.
Site. Then the exact site of the mass, sir. Then site size and site, of course. Then whether it's endophytic or exophytic, I'd like to see. In the staging per se, I'd like to see whether it is going into the pelvis, whether it's invading the perisinus fat, whether any renal vein involvement is there, whether it's breaching the gerotas fascia, or any going into any adjacent organs, sir, for the T cells.
Okay, so now it is very easy now because when you focus your vision as per the TNM staging, right?
Yes.
And again, T stage something is missing. T staging is the adrenal is missing. You missed two things: tumor, thrombus, and the adrenal, right?
Yes, sir.
Okay. So, and next is N means lymph nodes.
Lymph nodes.
And second is metastasis, last stage.
Yes.
And other kidney.
Yes, sir. Contralateral.
So remember, if you remember like this, in any malignancy, you have to see images as per the TNM thing. So you have to describe the T things first. In kidney, you have to see size, site, okay, and any venous anomaly, arterial anomaly, venous thrombus, okay, and adrenal.
Yes.
After that, lymph nodes, any metastasis, and other contact of kidney. That's only these things you have to see.
Yes.
So you have to go by this. You will never miss anything if you know what things to be seen as per the TNM stage. Okay?
Yes, sir.
Yeah.
And in the end, mention the renal score also.
Yeah, if it
Yes,
is.
sir. Yes.
If you should.
Yeah.
If you are planning surgery, better put the renal score in the end. Whoever has put this slide, I can't see much on this. I mean, I don't know how that pelvic elation system was aborting or something. I can't see on any particular slide.
So there are.
Swastik, show the other slide.
Sir.
Now, can you just tell us the different scoring system?
Various scoring systems, sir. Hello.
Yeah, tell us.
So one is the renal nephrometry score. Then there is Padua score. Then there is zonal nephro score. Then there is arterial complexity score, and then there is a DAP score.
Centrality index.
Elaborate everything.
Sir, in renal nephrometry score, we use the largest radius of the mass. Then the mass is exophytic or endophytic. Then the nearness of the mass to the pelvic axial system. Then the anterior or posterior, and the mass is in the polar lines. And then in the zonal nephrometry score, we again see the nearness. Then there is. Then we also see the radius, the diameter of the mass.
Miraj or Tanmay, can you just help him out?
Yes, so renal nephrometry score will, as I said, will have the first one is the diameter. It will be divided into less than 4 centimeter, 4 to 7 centimeter, greater than 4 centimeter, score of 1 to 3, depending on that. Then if the tumor is exophytic or endophytic, so the greater than or equal to 50% exophytic, less than 50% exophytic, and completely endophytic will be 1, 2, 3. Then nearness to the sinus or collecting system, the millimeters distance from greater than 7, 4 to 7, or less than 4 mm, and anterior posterior or anterior posterior, that is derived as suffix. And finally, location with respect to polar lines, 1, 2, 3 will be completely above the upper pole, completely below the lower pole, lesion crossing the polar lines, and greater than 50% of the mass crossing the polar line. That will be the renal score, sir. When coming to the Padua score, sir, that firstly the longitudinal distance between the polar lines is seen, then whether a medial or lateral tumor infiltrating PCS or not, infiltrating the renal sinus fat or not, and exophytic or endophytic. These parameters are seen. Centrality index is a ratio of the midpoint of the tumor to the midpoint of the kidney divided by the radius of the tumor.
So renal score will be how much?
Renal score in this case, the size less than 4 centimeter with the mean more than 50% exophytic tumor with the nearness to the upper pole with so looks like a posterior tumor. That's an E with the Region almost, so it will be 4, 5, sir. It will be renal score of 5.
Show them the renal score.
Sir. So this is a CT report, sir. In the report, sir, there was evidence of well-defined, smoothly marginated.
Now, excuse me, just you go back.
Yes, sir.
Then may now recalculate. And now you see the score, right?
Yes, sir.
Now you correct yourself. Then you will learn how to see CT scan. Everybody will learn how to see, how to measure the score in a CT scan.
Okay, sir. So firstly, the radius 3.4 centimeters, sir.
Okay, score 1.
So less than 4 centimeter, 1, sir.
Yeah.
Then exophytic or endophytic, sir. It is partially endophytic, sir. Like,
so it is 1 or 2?
It will be 2, sir.
How much now?
3.
3. Then
nearness to the pole, sir. It is
seems to be crossing one line.
Seems to be crossing, sir. Seems to be
So,
crossing the line. So
then
that will
score?
be 2, sir.
How much?
5.
5. Then
anterior or posterior looks to be a posterior.
it doesn't have point. It just only a suffix, right?
Yes. Yes, sir.
Next, if you see the central picture, if you see the central picture,
yes, sir.
There are 9 pictures with the central one. Okay.
Yes,
so एकदम center में है. This is, I think this is near to PCS system. It should be 3 actually.
Okay.
Because just abetting the renal hilum.
Yes, sir.
Right. So score, I have not all picture, but by this is my, as per my this thing is 8P, not 7P.
Okay.
So this is how you should measure this thing, by calculating score 1 by 1.
Okay, sir.
Carefully. Okay. Yeah. Any doubt? Anybody can ask if they have a doubt. So if you see the right sequence, the middle one, where the arterial anatomy is there. So here you can see here it can be 2. If you see that the arterial anatomy is there, there is some distance between the margin and the pelvis system. The parenchyma is there. Okay, here it can be 2. Okay?
Ideally, it is good to see that particular parameter on an excretory phase film.
Yeah.
Because here, whatever you are describing, both is the area which is called renal sinus fat. If you have an excretory phase film, then it shows very clearly how much distance is there with the tumor and the PCS.
You got it? What sir wants to highlight?
Yes. I think the top right image is the excretory phase.
You did say, but here triphasic CCT, I would consider. So
yes,
there should be use of all these phases when you are actually seeing the CT scan anatomy.
Yes, sir.
Okay. Next.
So what is the use of renal score or Padua? How often do you use Padua in your practical work?
Very much.
The complications that are possible after surgery.
Answering the first question, it tells you about what? Loudly?
The complications after the partial nephrectomy, that is leakage and the bleeding.
I didn't get complication pattern, you said.
Complications after nephrectomy, partial nephrectomy.
I'm sorry.
Remember 2 words: complexity, and complications. Complexity of the renal mass, which will leads to complexity of during the surgery. Okay, and more complex surgery leads to more complication. And this will also use for the counseling of the patient. More the score, more complexity, more complications rate, patient may end up in more blood loss and maybe postoperatively more complication, and then the nephrectomy, either intra-op and post-op, if we develop complication, right?
This is for partial nephrectomy, sir, or total also.
No, total, if suppose that score is only for the where the partial is feasible. If whole tumor is kidney involved by the tumor, how will you do the score? Right? You cannot cannot measure the score.
The complications related or assessed or which are to be suggested by this score. If I'm doing a radical nephrectomy in this particular case, I don't think they will arise in a radical than the partial.
And remember one thing, if you are very expert in laparoscopic radical nephrectomy, and this surgery can be done open partial, okay, it should be open partial, not the lap nephrectomy, because you are expert in that. Clear? Yeah.
Yes.
Yeah.
We go ahead.
Yeah.
So this is a city report, sir. Should I read it out? So there was evidence of well-defined, smoothly marginated soft tissue density mass seen involving the upper pole of the right kidney with partial exhibiting extension. It measured approximately 3.3 into 3 centimeters in size on axial dimensions with craniocaudal extent of 3.4 centimeters. Exophatic component of the lesion is extending into posterior parallel space. The lesion is abutting upper calyx without obvious incision. On dynamic post-contrast study, mass shows intense heterogeneous enhancement of both arterial and late arterial phase images with intrinsic non-enhancing areas of necrosis. Bifocal ostial narrowing of the right renal artery was seen. In addition, great focal narrowing of the origin of left artery was seen. A thin caliber accessory renal artery was seen on the right, arising from aorta, just proximal to the origin of right main renal artery. There is no evidence of renal vein thrombosis seen on either side. Bilateral renal cortical scarring was seen. There was a duplex collecting system seen on the left with duplication of left proximal and mid ureter. Duplex ureters were seen uniting distally and having a common opening into the urinary bladder. And the renal score was calculated to be 7P on this scan. And the impression of the city was this, suggestive of a neoplastic etiology for renal carcinoma.
Okay. So what is Bosnia classification?
It's a
Bosnia
classification. Yeah, good.
Bosnia classification is used when we have the renal cyst and we have to like further manage how we can manage further cyst. It can be used for CT, CCT, and can also be used with MRI, but mostly for CCT. And it is divided. It divides cyst into following classification, like type 1 cyst, following parameters are taken into the consideration, like the cyst wall, the content of the cyst, any septation, any calcification, and the enhancement. Depending upon that, it is further divided into type 1, type 2, 2F, 3, and 4. So, depending upon the type, we can decide the further management of the cyst. Like in type 1 and type 2, we can observe and have further follow-up and further keep a follow-up of the patient. Whereas in type 2, can also be followed up. Whereas in type 3 and type 4, there are in type 3 there is around 35 to 50% risk of malignancy, and type 4 there are around 70 to 90% risk of malignancy, which requires intervention.
So what is the characteristics of the cyst in type 2, 2F and 3?
So, sir, in 2F, the cyst wall is thick. 2F, the cyst wall is thick cyst wall. The content of the cyst will be clear. The septations will be again thick septations. The calcifications will be thick calcifications, and there will be no enhancement. Whereas in type 3, there will be thick walled. The content of the cyst will be turbid. Then the septations will be thick walled, and the calcifications will be post calcification, and there will be enhancement. 2F and 3.
Okay. So 2F has minimally complex multiple hairline thin septa or smooth thickened walls.
Hyperdense.
Yeah. Or
Hyperdense. with more than 3 centimeters.
Calcification may be present or some part of the wall may be thickened or nodular. And generally they are well having good margin. The margins are not irregular. 3 is denser, irregular,
Enhancing septa.
enhancing septa, thickened septa. 2F is all hairline. That you remember. So what next? You have the CT findings. Now what will you do next? Chest X-ray Q.
CT of the chest, ALP
CTQ.
level, serum calcium to look for any metastasis.
Okay.
ALP levels, the metabolic panel with CUE serum calcium levels and LFT and serum creatinine. Okay.
Why do you want to do metabolic this parameters in this case?
For AL, yes. ALP I want to do, sir. Metabolic panel.
Why patient is having any body ache, something like that? You have a doubt of any body mats?
No, sir.
Anyway, in LFT it comes if you want to do LFT. And if you do not know any investigation, why are you doing that? Please don't say it. Okay. Yeah. Then
So, 50-year-old female with tumor shown in the CT and the renal lymph node is coming to 7P comes around localized renal cell carcinoma. So I like to explain the patient the what disease he has and the with the family, and I like to go ahead with the surgery. So I like to go ahead with I like to explain patient that the partial or nephron sparing surgery is feasible here, but there is considering the CT findings and the nephrostomy score, the complexity and complications following the renal this nephron sparing surgeries.
Ajinkya,
Yes, sir.
the patient is saying, doctor, how are you so sure this is cancer? Why don't you biopsy the tumor?
So this is the CCT is suggestive of this, and it is a localized disease. And if we are planning to go ahead with the complete resection, I think
How
it is
are you
not
so
necessary
sure
to biopsy.
this is cancer? What criteria of CT scan can confirm that it is the tumor? This is malignancy.
It is.
The enhancement of around more than 15 HU as compared to then the heterogeneity of the lesion.
So again, indirectly, I want to know indirectly what are the indications of biopsy in a case of renal mass.
So there are two indications of biopsy, like if we are planning an active surveillance in the patient, if we are going to plan any targeted therapies or focal therapies to the masses, if we are not sure or the CT or the other radiological investigation are not being in the diagnosis, and in case patient has already a malignancy somewhere, we are suspecting a metastasis lesion in the kidney.
Or
also if you're planning for an upfront chemotherapy.
Chemotherapy.
That he said, and again the doubt of lymphoma or an abscess, right?
Yes, sir. Any inflammatory
disease. Okay, fine, sure. So you explained the patient and you're planning for okay. There are how many types of nephron sparing surgery, and anything else you want to do in this case? DTPA scan, something you would like to do?
So I'd like to see the delayed images of the CCT, sir. If there is prompt excretion of dye, and then I think there is no need of DTP at present.
So when will you do DTP? If this patient doesn't need DTP, in which patients you will like to do DTP scan?
If there's a doubt on the renal function, sir, the marginal renal function, we'd like to see which is the better functioning kidney. If there is a decreased excretion of contrast from that particular kidney on the contrast and scan, I'd like to see.
In CT scan, can you identify which kidneys kidneys having reduced contrast excretion? Sorry.
The delayed phase, sir.
It can be normal.
You can't quantify.
So there are some absolute and relative indications of doing DTP scan. Anybody can tell? Ajinkya, Miraz, and Tanvi. Single kidney,
Patient with end-stage renal disease.
bilateral tumors, right? DTP scan. These two are the absolute indication. Okay, and relatives are in which any disease or any process in which kidney may have reduced kidney function in future, like diabetes, hypertension, uncontrolled, previous history of renal surgery, okay, history of a stone surgery, stone disease, right? History of pyelonephritis, all these things. These are relative indications of doing DTP scan. Okay, so whenever there's an indication, remember as a 2-point, either absolute and this thing relative indications. Okay, this is how you should remember the things. Okay, and if you say in exam like this, examiner feels good actually.
Okay.
Yeah. Research are not mandatory, relative. Okay, you have to. It should be individualized. Okay.
Yes.
Okay.
So if examiner says not mandatory, why you want to pursue it? So you will have to justify saying something like, we would like to optimize the peri-op and the post-op management when we know what we are doing with the kidneys.
Yes, and to counsel the patient regarding the possibility of
of renal dialysis, which might be peri-op or no.
Yeah.
Sir, would we go for a chest CT, sir, in this case?
That you have done before during staging.
Yes. I mean, in this case, we just got the lower thoracic cut.
So you can do.
Was small.
If CT is not available, you can say CT actually suffix actually.
So NCCN guidelines do say chest X-ray. They allow it.
Yeah.
EAU guidelines, I think, still say chest CT. कोई तो क्लिनिक के साथ गाने भी सुन रहा है.
So Ganesh, if this is a low risk, less than 4 centimeter mass,
the chance of metastasis is less.
So in this case, if we do only X-ray chest, of course, it is always better that we do, CT, abdomen, pelvis, and chest at one go. But by chance, if it is not done, and again, instead of subjecting in the exam, if they say there is a low risk and I will do only X-ray chest, is it okay, or they have to say?
It is okay because NCCN guidelines do support you.
Okay. So
but there is a chance that CT scan will pick up 26 to 30% more lesions than the X-ray chest.
So this they should know it. Fine. So you have evaluated this patient, okay? And now next what? You have, with a sympathy, empathy, you have explained everything to the patient. So next what?
So I'd like to go for partial nephrectomy on the right side. Open partial nephrectomy because we do that more often in my centers.
Why open?
So there is
today's word, everything is going about the minimally invasive. Why do you want to do a open partial?
More because I am I have not seen any laparoscopic
Be
cases.
honest. No. You should be honest, because I am confident. I'm confident doing open surgery.
Yes.
If patient wants minimally invasive, I will refer to higher center.
Yes. Yes.
This is the honest answer. Okay.
Okay.
Yeah. Okay. So you want to do a open partial.
Yes.
Can you tell the different type of partial nephrectomy?
So be an enuclear resection or a wedge resection or
Polar segmental
Polar, segmental, and
transverse.
More something more
transverse
radical. Something.
transverse.
हाँ क्या बोलते हैं उसको यार ये
हेमी
transverse what is
बोलते हैं,
called?
हेमी नेफ्रेक्टोमी.
Yeah.
Hemi.
and
Okay. So
Anything else? Okay.
So can you describe how will you do the open partial nephrectomy?
Consider the same patient for the incision.
first we will take a subcostal extended incision on
Which
the
rib?
right side across the 11th or the 12th rib.
How to decide?
How can you have a subcostal incision on the 12th rib? Subcostal means below the costal. So this is a upper posterior tumor, right?
Yes.
What is the common idea of taking the incision?
Good
You should know why you
accessibility.
take some incision. You take the incision at least for the reach, or to dissect the kidney, or to reach its hilar structure. So here, why you want to take subcostal, or why you want to take whatever rib you said? I didn't understand that.
It's a small tumor of the upper pole.
Ah,
Oh,
then you can take phalansteal also.
thoracoabdominal incision or the subcostal incision.
Tanmay, which one?
I
Which
prefer
incision?
11th rib cutting incision. Sir.
You must have seen so many open parallelothotomy, so many open
Yes.
nephrectomies, right? So ever you never this thing have a query ki how do we choose incision?
By mistake also, don't tell in exam subcostal incision for any renal malignancy. 4 centimeter, 10 centimeter, 2 centimeter, कुछ भी रहने. Because देखो, it is depend upon the size of the tumor, site of the tumor, lower pole, upper pole. Then early, if you are following the principle of malignancy, then transabdominal. If you are not, if you are going by urological way, it is a flank. Then it is upper pole, thoracoabdominal. What is the size? ये सब चीजें tip of tongue चाहिए. If you start with subcostal incision, then examiner will get irritated and unnecessary viva will go here and there.
So even when we are doing regularly donor nephrectomy, we always take a 11th rib.
11th ribs.
So now it is very standard. And if, as Dr. Gite said, if the mass is big, upper polar, and you think that you want to, control the hilum, and then you can say thoracoabdominal, or sometimes some onco surgeons, they also take a midline incision, big midline incision.
कुछ भी नहीं समझाना याद नहीं है तो 11th rib bed incision इतना बोल लो.
But also you should know why.
At least तो थोड़ा सा तो accept कर.
Yeah, but you should know why 11th rib.
Yeah, that is.
Okay. So ठीक है. You what are the other type of incision for nephrectomy?
Could be a thoracoabdominal or a midline incision for a transabdominal approach.
Even flank incision, types of incision, flank incision.
Supracostal 11th rib cutting. Then there is.
Is it
flank
not?
subcostal.
Is it not 11th rib? It's a rib cutting incision. 11th
Rib cutting.
rib, don't specify. It's a rib cutting. Okay.
Okay, rib cutting.
Yeah.
Yes.
Flank. Okay, fine. Okay, you took the incision. 11th rib, cutting incision. Then go ahead. Describe.
I'd retract the peritoneum, sir, medially, and expose the Gerota's fascia. And, go and loop the ureter and see if dissect the renal hilum, sir.
How to reach renal hilum? Renal hilum.
Go posterior, sir.
Which plane?
And Gerotas and the this retroperitoneal.
What? Psoas fascia. Okay.
Yes.
If you go in this correct plane, you will definitely reach to the hilum very fast. If you lift the psoas fascia, you are in wrong plane. Then you are searching for the vessels. Okay. Then after this,
we'll loop the artery and the second keep it loop. Then we will dissect
that this is surgery of in 5 steps. Rib cutting, mobilization, taking the hilum, artery clamping, tumor cutting, and rhinorrhaphy and the closure. Okay. What about the ischemia time? Something. No, in this case, you will have to do no ischemia or warm ischemia and cold ischemia.
Warm ischemia will be sufficient.
Warm ischemia should be sufficient, sir.
Okay. So you will clamp both artery and vein?
Only
arteries.
Why not vein?
So because the vein can give retrograde perfusion to the kidney while the surgery is being done, and secondly, the venules will have some back bleeding, which will point them out during the rhinorrhaphy to control for a better hemostasis. So
you're worried about the venule bleeding, not the arterial bleeding. Okay.
Any back bleeding will be visualized better without clamping.
Okay.
There are studies which suggest either both.
So which is better? No ischemia, warm ischemia, and cold ischemia.
So no ischemia better than okay. Depending on the duration, if it is within the stipulated duration.
Okay. So what is the logic behind cold ischemia?
It is decreasing the metabolic activity of the kidney, which will in turn decrease the oxygen demand, and that will ultimately reduce the number of reactive oxygen species that are formed due to anaerobic respiration. So on declamping the renal artery, on releasing the clamp on the renal artery, these reactive oxygen species will cause oxidative damage onto the tissues. So to prevent that.
So it is a surface cooling, and it main aim to cool the cortical area, which is the metabolically most active part of the nephron. Okay. So this is your reason is right, but this is the another additional logic. Okay, fine. So what was done in this case? Anything else, Bakshi sir, want to add? I missed something.
Nothing.
Okay. क्या किया फिर इसके बाद?
We can ask a question on techniques of rhinorrhaphy and ways of hemostasis.
Yeah. Anybody can take the question.
Techniques of rhinorrhaphy, one person take, and somebody tell us how to do hemostasis for a partial nephrectomy. Yeah.
For hemostasis, figure of 8 stitches will be put on the vessels which are visible and bleeding, and the PCS will be sutured also.
I think you should speak little loudly.
And for rhinorrhaphy, we will use Vicryl in order to close the capsule, along with a pledget of gel and Omentum.
You could plug it with Gerota itself.
So you routinely in your institute you use a gel foam and Momentum.
No, sir.
Then why don't you at least say what you are doing actually? Because examiner might ask you any question. If you are not able to explain, then there will be a problem. I asked you about rhinography. You said we use Vicryl. You never said how to do the rhinography, which was more important than the suture material. We might use a Vicryl, you might use a monocryl, you might use a V-lock or a Stratafix. A small question. What is Vicryl?
It's an absorbable braided synthetic suture.
Absorbable braided synthetic suture. But है क्या उसमें?
Polygalactic.
Polygalactic. So how will you do the rhinography?
Sir, it is done as continuous interlocking sutures with the bites that are taken at as much as the depth of the cortex is.
Interlocking suture. If you pull interlocking suture, it will cut through the whole depth if it is pulled too much.
Capsule and peripheral parenchyma.
You're inner raphe, na? Inner raphe. So what is the main purpose of for inner raphe?
To ensure hemostasis and to prevent any urine leak if you're gone into.
How to prevent urine leak?
In case we are opening the pelvic access system, we close the pelvic access system first and then the rhinography in 2 layers.
Okay, so you want to rhinography en masse or
2 layers?
2 layers.
2 layers.
Like what? What 2 layers?
So the cortex and the periphery will be the superficial layer, and the deep layer will be cortical medullary. Or if pelvic system is open, first I'd like to close the pelvic system and then.
Why not close in mass vessels, pelvis, PCS system all together?
A high chance of a fistula being formed between the vessels and the pelvic.
Yeah, right. It should be individual. Good. Okay, fine. Okay, so you do. Okay, fine. Next.
Sir, I had a doubt actually. Is it like I've seen both methods being employed? Is it necessary to put a ureteric catheter and check for leak later? Like, do we mention that in our procedure?
Something is called conventional thing, and what makes you comfortable. Okay.
So it's not a standard thing to do if you are suturing properly. But some people have the habit to check it, but that is an individual habit, not mentioned anywhere that you should be doing it.
Only drawback is that suppose that because when we suture the PCS system, and when we push the dye from the ureteric catheter, you will always find some degree of some ml or millimeter of milliliter of this thing leak from your suture. Then you always you again try to suture it again and again, and it will create more injury to that. Until it is too large, that means you have opened the major calyx. Then you have to put a DJ stent.
Okay.
It is individualized, but if you place the ureteric catheter, it may help in identifying the injury to the PCS. May not be for confirmation of the watertight closure, but whenever there is minor injury to the PCS, it is very easy to identify that particular area whenever there is a ooze everywhere all around. So, but it is not mandatory and it is not given in. That's what as like sir says.
So now in this patient, 2D echo was showing only 15% of ejection factor, even though there was no history of any breathlessness or anything. So when we did pre-operative workup. So now, what are the alternatives?
Here we'll like to know the cause of that patient has no other comorbidities and might be on free of ejection factor is only 15%. So I like to involve a cardiologist along with here to identify the cause of such a low ejection factor, and then we can work up and build up the patient, and then whatever reason is correctable, correct it, and we can.
It was done maybe cardiomyopathy, congestive heart failure, something like that, and LVF was 22% after the treatment after 2 months. Sir, क्या किया था इसमें?
Again, we are waiting. We are waiting.
Okay.
You want to ask anything about the small renal mass, or we go ahead? Different alternatives. What are the?
Yeah. So what will you do now?
So I'd like to counsel the patient regarding the diagnosis of renal mass with the high likelihood of malignancy with the current comorbidity of the patient, and regarding the survival and the metastasis in this patient, I'd like to give an option of active surveillance because it's less than 4 centimeter mass and she's having high comorbidity for surgery. And I'd like to follow up, and in that case, I'd like to do a biopsy to confirm the histological illness.
Okay, your patient was very happy with your strategy, and you do CT scan after 3 months, and mass is now 4.2 centimeter. Yeah, you can say 4.2 centimeter now. Renal score is almost same because mass increase exophytic part.
Okay. So, in that case, I'd like to say that greater than 4 centimeter mass, there's with an increase in size within 6 months. So there's a high likelihood that the mass will grow further and lead to more metastasis. So I'd like to do a metastatic evaluation and, if possible, get a cardiology consult for optimization of the patient and take up for a partial.
It was done already. 22, if you will give GA, patient BP will fall and patient will have cardiac arrest on the table. Very, very high risk of surgery due to cardiac risk. Now what?
In that case, I'd like to counsel regarding focal ablation therapy for this patient. Even though it's slightly greater than 4 centimeter, I'd like to explain that considering her current condition, that might be a better choice.
Okay. What type of ablation therapy you like to offer?
Thermal ablation therapy, sir.
Okay. What about radiation?
Radiation as in radio frequency ablation or radiotherapy, sir?
Radiotherapy. And which is better, cryo and RFA? Which is better?
Cryo is better, sir, because the penetrance of cryo can be controlled much better than radio frequency ablation.
Disease-free or the recurrence-free rate is also less with cryo compared to.
There is no head-to-head study. Okay.
Yeah.
So, and we were not having very large study. So exactly, we don't know which is better. Okay. What about radiation therapy?
Radiation therapy has no role.
External stereotactic therapy. Radiation.
Now few studies are coming which have in high dose. So previously it was assumed that it is a radio-resistant tumor, but now on high dose it is assumed this is the radio-sensitive tumor. So few studies are there, but it is not a standard of care. So whatever in this scenario, you have to explain the patient. Partial effect surgical treatment is the best treatment for this giving the stage, but for the given comorbidities, we have to offer some suboptimal options like RFA, cryo, and the radiation. Okay.
So my question is, suppose if such a patient is there and you want to do surgery, don't you think that in that case the radical nephrectomy will be better because you can go inside fast, know much of the blood loss, and you can do the surgery very fast?
Yes,
You
sir.
can
Given
do
the
that, sir. But
yeah.
what happens is the articles which are published with many times with radical nephrectomy, finally the end morbidity with that is cardiovascular disease. So in a way, if you take note of these publications, you are adding up the cardiovascular mortality. So if EF is only 15%, then ablative therapy probably is a better treatment if you want to consider something. Otherwise, active surveillance is suggested for CT1A tumors, that is less than 4 centimeters in all guidelines except AUA, which say that for active surveillance it should be only 2 centimeters.
So overall consensus is no radical nephrectomy for T1 tumors when partial nephrectomy is possible. Here we are deferring a partial nephrectomy not due to his size or the tumor related factor, but the patient related factors. Okay. So if you are planning any surgery, the surgery is partial nephrectomy.
Yes.
Fine. So we'll see now. I will explain to the patient and then we'll decide. So can we go for a second case now?
Yes, sir.
Okay, fine.
Yes, sir.
First case.
Yes, sir. So scenario 2, sir. A 42-year male presented with complaints of bilateral flanks along with episodes of hematuria for last 1 month. Pain was dull, aching in nature, insidious in onset, non-radiating, gradually progressing, and no specific aggravating relieving factors were there. Hematuria was total, painless, associated with clots on and off, and there was no history of taking anticoagulants or antiplatelets. No history of burning micturition, no history of fever associated with onset of pain, no history of vomiting, no history of lithuria, no history of increase or decrease in frequency, no history of facial puffiness, and lower edema, no history of jaundice, no history of altered bowel habits. Patient was conscious, cooperative, well-oriented, time, place, and person. Pulse was 90 per minute. Karnowski score was 90. Blood pressure was 110/70 millimeter of mercury, respiratory 18. He was afebrile and saturation 90% room air. There was no evidence of bilateral sinus clogging, lymphadenopathy, or edema. Spine examination normal in this case. Per abdomen examination, it was grossly normal size inspection. Umbilical central place, all coordinates moving equally with respiration, no scars, sinuses or engorged veins were seen. Palpation, no localized or temperature, no tenderness present. Bladder not palpable. Percussion, timbering was present all over the abdomen. Normal liver dullness span was there, and auscultation was normal. Bowel sounds were present. Respiratory CNS and CPS were normal, and per rectal examination was normal. So it was hematuria and bilateral flanking.
Yeah. So Ajinkya, now tell us. This is a story and this is a history. So what is your diagnosis or differential diagnosis? And what are the now next? What you want to do?
Considering bilateral flank pain with hematuria, the first differential diagnosis I'd like to check is the bilateral stone disease in this patient, and then could be bilateral stone disease and bilateral cystic disease with the complications. I'd like to further investigate, sir, in this patient.
So what investigation you like to do?
So apart from routine blood investigations, I like to say basic electrolytes. I like to have the ultrasound of abdominal lipids.
Ajinkya, just tell me which part of urinary tract, which parts can give hematuria?
So kidney, ureter, bladder.
So why your wisdom was only focused to the stone and the kidney, not other things?
No, the bilateral.
You just said about the bilateral stone disease and some kidney,
yes, sir,
like that cystic disease. Why not the other in the ureter, in the bladder, in the prostate, in the urethra? Why? Patient having total continuous hematuria with bilateral flank pain, right?
Yes, sir.
So now can you add
so
something?
Can it be CA bladder pressing over both the ureter?
Yes, sir. Could be.
Then, so Dr. Mahendra is asking you the same thing. That means you know that this patient has got a bilateral renal problem.
Yes, sir.
You
And
understand?
continuous cross immaturity.
So it can be a bladder mass,
That-
a big bladder mass pressing over the ureter. It can be like,
Stone.
bilateral.
Large stone.
Fine. So what are the investigations or what you want to do now?
Sir, ultrasound of abdomen. Pelvis.
Only ultrasonography?
Patient having bilateral flank pain, which gives some hint. Patient having hematuria, which again gives some hint about the other test other than ultrasonography.
Urinator microscopy
And renal and
sir, cytology.
Patient is bleeding. Patient is bleeding. What thing?
Coagulation.
Not hemoglobin.
Yeah. Yes, sir. I took CBC creatinine.
So why creatinine?
because it's
part of the
bilateral
routine.
flank pain, so
Bilateral.
there'll be a chance that there'll be bilateral obstruction.
Right? And if there's an obstruction, what else you want to know? Electrolytes.
Electrolytes. That is.
Now patient is having hematuria. What you want to do? What is the investigation panel for hematuria? What investigations are there?
PTINR, APT,
Okay.
PTINR, APTT,
Urine
Okay.
cytology.
Cytology.
CBT.
Right?
Yes.
Okay. Cognitive. You have to do that. Okay. Then simultaneously you can do sonography. So when patient will come to you, he or she will come with all the reports.
Yes.
It will save time. Right? Okay.
Show them the investigation.
Okay.
During the 11.7, TLC was 8,578, platelet count was 90,000, sir, and serum creatinine was 1.23. Urine iron showed RBCs 12 to 25. RBCs was 10 to 12, sir. There's a typing error, sir.
Show them sonography.
So the sonography suggested evidence of the right kidney was 7.9 to 4.5 centimeter in size, with evidence of 4.2 millimeter calculus at the mid pole. Left kidney was 7 to 4.7 centimeter in size, and urinary bladder had a heterogeneous interluminal gravity-dependent content which was not attached to urinary bladder wall, seen at the base of urinary bladder. Then, sir, evidence of bilateral solid renal mass lesion noted in upper part of right kidney measuring 8.4 into 6.6 centimeter, and lower pole of the left kidney measuring 6.6 into 6.3 centimeter. And it showed multiple tiny cystic spaces with thickened irregular septa between them. There's a peripheral and vascularity noted on. So it was advised to undergo a CT
Now
scan.
what? Ajinkyan, this is a sonography report. We have not done cytology. You want to do cytology now?
No, sir. You can straight away go with contrast and a CCT of the pelvis, sir. To look for the type of the bilateral.
So you want to do CT scan only abdomen and pelvis, or you want to do the full, even the chest?
Why did you ignore the bladder lesion?
So it is suggestive of what I cannot understand. Some blood leak.
Some heterogeneous intraluminal
Not attached to the urinary bladder
content.
wall, sir. Could be clot, sir.
Again, I think the Doppler of this lesion can differentiate the clot or the lesion.
Mass.
Okay, or the mass.
Okay.
Okay.
Show them. CT scan.
This was a CT scan, sir.
See, you can enlarge it on your screen. Okay.
I have marked both right and left lesions with the arrows on different screens, sir. Different cuts.
First, show them all the CT scan.
Sir, this is the first image, sir, and
Any other image?
yes, sir. Second image, sir, and then there is another image, sir. This one. All these three are the images, sir. CT abdominal pelvis.
So Tanmay,
Yes, sir. So there's a plain CT scan of abdomen with the oral contrast, sir, with the bilateral renal lesions noted. On the right side, there's an upper polar lesion measuring around 8 centimeters in the largest dimension, with which is heterogeneous in nature, which is having multiple areas of soft tissue within it, and the lower pole of the kidney appears to be free. It appears to be involving the pelvic calcium system, totally replacing the renal parenchyma on the upper pole. And on the left side, there is a lesion arising from the interpole of the left kidney, which again is heterogeneously enhancing, which appears to be infiltrating the pelvic calcium system with again soft tissue enhancement, noted, soft tissue content noted within the lesion, sir. With no obvious lymphadenopathy noted, no liver appears to be.
So what is the relevance of the soft tissue content you are saying?
Because it looks like a cystic lesion, so soft tissue content would be like a Bosnian 4.
When you say heterogeneous lesion, heterogeneously enhancing or solid cystic? Heterogeneously enhancing solid cystic lesion.
Yes, sir. It would be a solid cystic lesion with heterogeneous enhancement.
so
Should I go to report, sir?
yeah, so read the report.
Sir, both kidneys are normal in size, shape, location, and show equal and prompt enhancement and good excision contrast medium. No radiopaque calculus was noted in kidney on either side. The pelvic calcium system ureters are normal. No hydronephrosis or renal pathology is noted. Well-defined lobulated heterogeneously enhancing lesion arising from both kidneys measuring 8.5 into 6.9 into 6.7 centimeter in upper pole of right kidney and 8.2 into 7.7 into 7.3 centimeter in the interpolar region of the left kidney. Lesion shows no extension into renal vessels or pelvic calcium system. Aorta IVC pelvic vessels are normal. No pre or para aortic or pelvic lymphadenopathy is noted in this. Urinary bladder is distended with normal ball thickness. No interluminal soft tissue mass is noted in the bladder. Both UV junctions appear unremarkable and prostate was normal. The impression was neoplastic etiology of both the kidneys with the differential including angiomyolipomas.
Bolo. Now what you want to do? Tanmay, what you will do?
So was this a contrast cancer? Because I couldn't appreciate any enhancement in the arteries. That's the only thing. It's a bilateral 8 centimeter tumor, sir.
Yeah, tell us.
So because it says that it's a lesion showing no extension into the renal vessels or pelvic elevation system, I would like to assess if the patient. Firstly, I'd like to do a metastatic evaluation, sir, a CT chest of the patient along with the LFTs and alkaline phosphatase.
So they are normal.
Then after ruling on metastasis, I'd like to offer a bilateral partial nephrectomy in this case, sir. Considering it's a bilateral tumor which is not invading into the pelvic elevation system, especially on the right kidney. Considering an upper port tumor, I'd prefer a right partial and a left radical nephrectomy.
Ganesh bhai, Mahendra.
So did you measure the nephrometry score in the both the mass before planning for nephrometry surgery?
So it's a very high score in both.
So how can you decide about the how can you decide about the NSS?
Only criteria being it's a bilateral tumor.
Okay, so you don't want to see the complexity of the masses?
I would like
or
to.
are you sure? Are you sure that you will be able to do nephrometry surgery?
No, sir. I believe it will be difficult in both sides.
No, you just said you want to do nephrometry surgery. So what things you will see other than nephrometric score to performing a nephrometry surgery, even in bilateral tumor?
Sorry, sir, I didn't get it.
What other factors you will see other than nephrometry score while deciding for nephrometry surgery?
So the function of bilateral kidneys, sir.
Okay, or did you do that over here?
No, sir.
It's the absolute indication of doing what?
DTPs. Yes.
DTP, right?
Yes.
You missed that.
Yes.
Okay. Then
functional remnant, sir, after doing the peer plan, if we do the coordination, how much functional remnant will be there?
So what is harm? You got success preserving 10% of the kidney parenchyma.
No,
what is harm of that?
We want at least 20% of the parenchyma to be preserved.
For what?
Renal function, sir.
To prevent the
end-stage
renal disease, but at the cost of reperfusing injury.
Yes.
Right?
Yes.
So all these things you have to think other than nephrometric score, while again the complexity. If this mass is sitting or involving the main renal vessel, do you think you will save the kidney? Or if you save the parenchyma, that will survive?
No, sir.
No, sir.
So in these tumors, you have to be very careful. You cannot say just NSS in the exam if this case is there in the exam. Right?
Yes.
In single kidney and bilateral renal tumor, you have to very, very careful while saying anything. Okay?
So now what to do?
So we can have two options. Like one is considering the size and the.
One more thing.
Yes.
Again, we missed something in this patient doing cystoscopy.
Yes, sir.
Right?
Bladder.
In sonography, there was some lesion that we do not know whether it is a bladder tumor or the clot. Okay, so
Yes,
to do cystoscopy to rule out the bladder lesion, the cause of hematuria. Okay.
Yes, sir.
Right.
So Mahendra, I am going to admit.
Yeah. Yes, sir.
So Ganesh and you. So how to go about?
So I think there are two ways how you can explain to this patient. The size of both sides is more than 8 centimeters. So even in good hands, I really doubt whether we will be able to have a very good successful nephron sparing surgery. That surgery is going to be too challenging. The better way to tell the patient is I would either assess you with a joint team of uronephrologist and do a radical nephrectomy on both sides and put you on dialysis, and then see the follow-up further. If patient is unwilling for that, then we can do the renal biopsy, check if that is a clear cell RCC, and then counsel about immunotherapy plus axitinib. I mean, pembro-axi or nivolumab cabozantinib combo therapies. Expect after 2, 3, 4, 5 months that there is a response in size reduction. And if we are possible to convert these radical nephrectomies to a decent nephron sparing surgeries.
Yeah, now this patient is willing. He says, he in fact, he told me that I explained him everything. So he said, okay, I don't want to take any chances. I don't want disease to be remain behind. So if you are in doubt, do the nephrectomy.
That is the best choice, sir. Then just go ahead with both surgeries, radical nephrectomies, and hand him over to a nephrologist.
Okay. So as you suggest,
if you are going to do nephron sparing on this patient, it is going to be too much of a challenge, and your margins are just going to scrape through. Whatever remains is going to be a very small nugget of renal tissue. Surgery is deemed with complications like bleeding and urinary leak. It itself is more damaging.
Okay, fine. So I'll do accordingly. Thank you very much.
We need a good metastatic workup before this, because both.
Yeah, I will do everything. I will. Tomorrow is getting admitted.
In size.
Yeah. I'll do that. Fine. Can you go ahead with
one more thing.
Yeah.
So here, like this, are we going to plan the radical nephrectomy simultaneously, or first with one kidney and then with the other kidney?
I am planning one after another, because it will be too much to do both the things together.
Yeah. So, sir, the question maybe the Ajinkya want to ask is a bilateral tumor. Which one to operate first? How to decide which one to operate first if we are doing a staged surgery? So I read one article long back which have a very good a table or maybe chart about the how to manage bilateral synchronous tumor. So there are 3 options: either remove both the kidney together and dialysis. Okay. Other philosophy is remove the larger mass first and attempt for NSS other, or maybe the radical nephrectomy in the smaller mass later. So a third, remove the smaller mass, which is easy to remove, fast surgery, and remove the larger tumor at last. In all the three scenarios, removing the bilateral tumor and removing the larger tumor first, they provide a better survival compared to removing the smaller mass first. And again, the management after, if it is a clear cell carcinoma, conventional, not grade 4 up to grade 2, permanent grade 2, patient can be offered renal transplantation after 1 year. But if it is aggressive pathology, okay, and maybe permanent grade 2 and 3, should not be offered transplant.
So Mahendra, one more thing. You were suggesting that we should do cystoscopy also. It's just an idea. So if we do cystoscopy and there is a clot, we remove the clot, and if we can see that one side is bleeding, the urine is like, hematuria is there from one side, then we can go ahead and do that side first.
Yes, sir. That means that is aggressive tumor which is involving the PCS system, and it's an invasive one.
So that is another thing. Otherwise, as you said very rightly, we will go ahead and we'll do the larger tumor nephrectomy first. Correct?
Yes, sir. And depend how the patient fitness is there. If patient is not able to tolerate dialysis post-operatively, another kidney can avoid dialysis for at least till the next surgery, then it is good for the patient.
Yeah. So we'll do one after another.
Yeah.
Fine. Okay. Thank you. Next case.
So one more doubt, sir. Actually, with the in this particular scenario, with the presence of hematuria, would you go for a targeted therapy followed by nephrectomy? Because in that time, the patient might be losing some blood to the tumor.
Why do you want to do target therapy in this patient?
No, sir said that's another school of thought, doing a target therapy.
Yes. It is thought ki by the giving targeted therapy, the tumor size may reduce.
Yeah.
Okay, tumor size, and we can able to perform the NSS, or maybe we can preserve one side kidney. Okay,
Yes.
can be done, but it should be also individualized, and it should be the shared decision with the patient and the doctor. But it is not a standard of care at present.
Okay. Swastik, next case, last one.
Yes. Scenario 3. A 73-year male presented complaint of episodes of hematuria on and off for last 1 week. No past history of similar complaints, no history of floods, no history of pain or fever, no history of loss. Has history of loss of weight over last 3 to 4 months, history of malaise and weakness, and is a diabetes mellitus, history of smoking present for last 30 years. It was 6 packs per year. Per abdomen examination, there was a palpable lump of size 12 to 10 centimeter present in right flank.
ये तीसरा केस है ना, तो सिर्फ पॉजिटिव हिस्ट्री बता दो ना.
Palpable lump of size. Yes, sir. Just abdominal examination से एक history थी. एक finding थी sir. Palpable lump of size 12 to 10 centimeter in the right flank with a smooth surface, forming consistently manually palpable. Moving respiration, fingers could be insinuated between lump and ribs, but upper margin could not define. And hemoglobin 9.2, creatinine was 1.9. And this was the findings. And had done an ultrasonography was done outside when the patient presented to us, sir. This was the
Read the impression.
Yes, sir. The impression was right kidney with mid to lower pole lobulated outline heterogeneous mass lesion with cystic necrotic changes and extensions as described. The mass was extending into precaval space and compressing the head of pancreas, portal vein, right vein, renal vein, not separately visualized from the mass lesion. It was likely a renal cell carcinoma. And advised for the evaluation. IVC was showing a heterogeneous tumor thrombus completely distending the lumen, and chronic cystitis and bilateral kidneys, hazy cortical echoes were there.
So now there are Ajinkya and all three of you. There are two things. One is that the creatinine was marginally raised. It was 1.9, and the sonography is showing that it is thrombus is extending into the vena cava. So how will you go about? Whether you want to still do the CT scan or you want to do other investigation? How to go about?
Sir, I'd like to do a non-contrast CT scan first, sir, before doing any other investigation. Because contrast.
Yeah, tell us.
Because contrast enhanced MRI will also be contraindicated with a creatinine of 1.9. So
MRI is not contraindicated anymore for a creatinine of 3-4 also. The earlier thought complication of nephrogenic ischemic fibrosis now considered to be of a very, very low risk with MRI new generation gadolinium contrasts. So straightforward, you can go for a.
In that case, definitely contrast enhanced MRI.
Contrast enhanced MRI.
But when you do contrast enhanced MRI, you can see only the vein. What about the other metastases, lymph nodes and the soft tissue?
So MRI is difficult to read, but you will get information about hilar lymph nodes and everything actually. What we would like to do is MR angiography because there is a IVC thrombus. And I would also definitely like to see if the IVC thrombus, if big, is infiltrating the wall overtly or not.
So, Ganesh, in this case, if you do the contrast, like 1.9 creatinine,
nothing will happen.
If you do contrast enhancement IV and the
Sir, with MRI contrast enhanced at 1.9, nothing happens now.
No, and CT scan, we can't go ahead.
CT scan, you can go ahead, but for a IVC thrombus, MR angio
Maybe better.
Is a better investigation.
Okay. So in exam, it is better to say MRI, or if, suppose the creatinine is now, because we hydrated patient and we treated him, the creatinine decreased. So then now we have done the thing, CCT. Okay. So
that is also okay, sir. I mean, only thing remains is if the thrombus is filling the IVC quite a bit, then the question arises in your mind if it is infiltrating the wall, which is not going to be answered by your CT scan, nor it is going to be answerable by the color Doppler ultrasound. That will use the level of the thrombus at the most.
Okay.
MRI angio will then tell us if it is infiltrating, if you want to find out that.
So whatever you said means MRI is far superior than CT scan in this case.
It helps with more parameters in this type of a case.
Okay, okay, fine. So anyway, we did the creatinine again, it had decreased. So we went ahead and we did the CCT. First, they just show that.
And we should do a metastatic workup in this patient.
Yeah, so we have done everything in this patient.
These were the images CT scans.
So it is an intrahepatic thrombus, na?
Yes, sir.
Yeah, it is going, I think, up to suprahepatic, just below the
Below subdiaphragmatic.
No, it is supradiaphragmatic.
No, no, sir. It is infradiaphragmatic. If you say intrahepatic, infradiaphragmatic.
Looks
It is not-
infradiaphragmatic, but above the level where there is a confluence of hepatic veins.
Yeah.
Yes.
And it is going right up to the bifurcation. And it is involving even the opposite vein also.
So in such
But the
case,
chest and everything is clear now.
okay,
Otherwise,
you ideally need a very good reconstruction of this these images before you operate.
fine. So can you just ask them the questions, all the different things, the staging and different things.
So
if
in
you can-
this, the question will be what kind of workup you will do and what will be the treatment.
So
So,
Tanvi, you start.
I'd like to do a metastatic workup in this case first, sir. Doing a contrast, doing a CT of the chest along with alkaline phosphatase levels if it's symptomatic, a bone scan, or and with that evaluation, full cardiac evaluation for planning a radical nephrectomy along with an IVC thrombectomy.
Okay. And how will you go ahead with the surgery? What is your steps or cross points of surgery?
So firstly, I'd like to take approach this patient through a vertical midline incision, sir, and
Vertical midline.
yeah, transperitoneally. I'd like to approach this tumor.
Okay, won't that be a little difficult?
Kochi incision, sir. The midline and the
Or
lateral
only
incision.
with a thread.
Personally, I would like that modified Makuchi incision.
Modified mark.
Then
So what are the chances that it may go into the atrium, and we should keep the heart lung bypass machine ready?
We'll keep a trans-echocardiography, trans-esophageal echocardiography also handy. It is extending up to the.
Maybe you will need, but if it is below the diaphragm, actually you should be able to mobilize the liver and the IVC and loop the IVC below the diaphragm.
And it is going on to opposite vein, renal vein also.
Secondly, the picture which was shown in the CT scan, the IVC is completely blocked.
Yeah.
I think this patient should be pretty stable. Otherwise, with the collaterals.
It is better to keep the cardiovascular surgery standby, and this patient may need a venous bypass because the thrombus is reaching right up to just below the diaphragm. So controlling the IVC when the thrombus is at the level of diaphragm is difficult, in spite of mobilizing the liver also. So such patients we should be ready with cardiac standby and may need venous bypass in this particular patient.
So my view is we should keep that standby, but I still feel that with the kind of blockage this thrombus is showing, this patient has well-established collaterals actually. The,
Agreed.
the blood from the lower part of the body is definitely going to the heart through alternate channels. And
Yes, you can see
that
it below
context,
also.
in that context, if we get control of the IVC above the thrombus below the diaphragm, rest of the dissection can be done with ease of time, aram se.
Agreed, sir. But if it is possible to control the IVC below the diaphragm.
Yeah, if it goes above, then we are anyway involving a thoracic surgeon.
Agreed, sir.
With this, we'll have to also take help of a GI, probably a GI surgeon.
Yeah.
It's the whole liver for us. We'll get the 3 hepatic veins which open up at a high end on the IVC. And with hepatic vein, the thrombus level above the hepatic vein, we are going to need control of the portal vein also. So that is going to be the problem part because we'll have to be quick because the portal vein circulation cannot be blocked for a long time.
So what are the stages of this thrombus?
According to the current TNM classification, there are T3A will be a thrombus involving a renal vein. 3B will be a thrombus involving the infradiaphragmatic IVC, and 3C will be supradiaphragmatic IVC or invasion into the wall of the IVC, sir.
Right. So, Ganesh, anything else you want to ask?
So steps पूछा था but किसी ने बताया नहीं मतलब otherwise.
Yeah.
What are the important steps are actually first you should go for the renal artery, preferably in the inter-aorta cable area because that is going to be the area without the bulk of the thrombus or the nodes probably in a right-sided tumor. Then once the artery is taken, that will achieve you whatever is the so-called maximum shrinkage of the tumor because there is no blood supply. Then you go on dissecting, isolating the renal vein, dissecting the whole kidney, taking off all the posterior feeders of the IVC. At least you will have to either tie them and cut in between or you will have to clip every single feeder posterior of the IVC. If this thrombus is going down direction in the IVC or the left renal vein, then you will have to mobilize or put loops, vascular loops at an area which is yet away from the thrombus. That is, for the left renal vein, wherever the thrombus ends, you will have to keep a loop for control. And the above one we discussed, probably I would remove the adrenal in this case. So adrenal vein has to be also taken care of on the right side. Liver, angular ligament and the whole attachment of the liver below the diaphragm has to be cut so that the liver can be rotated actually. And you can see the hepatic veins. We need to do this pretty early and then loop and keep it as a control. Once everything is done, you will need an incision around the ostia of the renal vein, right? And extend that incision onto the IVC to an length which is easy for you to quickly remove the thrombus. Possibly wash, remove all the bits, suture the IVC quickly in 1 or 2 layers as comfortable. Releasing the vascular clamps will have to be in that order so as to fill the IVC before the last suture closure is done so that there is no air embolism. then you have to gradually, sequential fashion, leave the clamps. That's it. Question I want to ask is, you obviously know this is a very large tumor, IVC thrombus, maybe some codes might be positive. How will you manage post-op?
Yes, Mastik. Ajinkya, Miraj, one of you please answer. Ganesh, one more thing. There will be too much of vascularity. So, ligature will be of this case. So, can we use ligature? It will be of a great help.
Sir, I think, sir, can I answer?
Yeah, please, please.
So if it is a large collaterals, so better to ligate them. Smaller, it depends how much blood flow is in them, because there must be also the chances of arteriovenous fistula also. So these venous channel will have a more pressure and the flow. So preferably should be ligated actually.
Okay.
Yeah.
Because once I had done such case, and we had to give, there was so much of bleeding. We had to give, almost like 15-20 bottles of blood. We had to give, platelet count was very low. We had to
Bleeding कहाँ से हुआ था?
Pardon?
Bleeding from where?
From
Retroperitoneum.
retroperitoneum.
Okay.
There was so many collaterals were there.
So
So
what
it
you
was,
do is, as I said, you take the renal artery first, and then you start dissecting just around the gerotas. Don't go too much on the retroperitoneum, because otherwise with a completely blocked IVC, there are going to be long channel veins sometimes which run directly from down to up.
The bleeding was so much, I think, sir, that same patient, no, which I was also there.
Yes, you were there.
We packed the abdomen with some 10-12 mops, and then we removed them after 24 to 48 hours. So much was the bleeding.
Okay, if you damage those veins, then bleeding is going to be colossal.
It was just
Veins
generalized
get
rules.
out
You
from
can't
the
make out.
gerotas outside, as Mahendra said, you should tie them off.
Okay. So we should ligate all the major vessels, collaterals.
Yeah. And
This is the
बाकी फालतू
safest.
जो कैपिलरी वगैरह रहता है वो
Yeah.
सब ligature हो जाते हैं.
Okay.
And
Fine.
I prefer to ligate the larger vessel first after taking the artery.
Oh, okay.
The question was, what do you do after the surgery, post-op management?
So I'd like to start the patient on low molecular weight heparin, give bilateral compression stockings, monitor the patient's vitals and renal function, considering the contralateral renal vein was also involved, along with the function tests. Give adequate fluids and transfusion to replace the loss of volume.
Anything more important? You have a midline incision, big incision.
Incentives, parametry, and chest physiotherapy.
Yes. And early mobilization.
Early mobilization. Yes.
Okay. Post-operatively, day 4. Patient BP dropped to 70. Drain clear. Output adequate.
I'd like to see the cardiac function in this case, sir. There's a high chance of a cardiac event after immediately after IVC trauma.
Okay. So patient having tuber thrombus, you remove post-op day 3 or 4, certain patient develop hypotension. So what will your first thought in your mind? BP 70, systolic.
Embolism.
Yeah, yeah. This should be your first pulmonary embolism. And this is an emergency, right? It
Yes.
has around a mortality of 60%. Okay.
So immediately do the 2D echo, and if required, the CT chest
Pulmonary.
Angiography. You have to do angiography.
radiography.
Yeah. Okay. And these high gravity cases have high chances of having pulmonary embolism. Okay.
So post-operatively, immediately we should keep them on the Clexane, na?
Yes, sir. Maybe first it's a normal. We are closing the normal vessels. No, not grafting. So I think normal is okay. No need of
Lexane
heparin.
is very important. And once they are ready to go home, sometimes it is better to put them on apixaban later on for
Okay.
5 to 6 weeks.
Two,
What
three.
happens is many times these big thrombuses, they are very much close or abutting or sometimes even damaging the endothelium of the IVC. So till it re-epithelializes completely after your removal of thrombus, these measures help to prevent venous thrombosis.
Two, three small questions. Define blunt. How will you differentiate blunt thrombus and tumor thrombus? How will you predict if this patient had a IVC invasion on MRI? Then how will you predict this patient need a graft with the help of MRI? When you will choose graft and when will you resect the IVC? So these are some 3-4 questions can be asked in this case, in these cases. So go and read it.
Roughly one of the answers to you is if the MRI, I mean for the students, MRI angiography, as I said earlier, if it shows some minimal annular contrast around the thrombus, very few at least, very thinnest rim, then the possibility of IVC wall infiltration is very less. You cannot see such a thing, and you are not sure whether the IVC is infiltrated or not if it is not a cross infiltration. Micro infiltration might be doubtful, it may be missed, it may be difficult to say. So in all such cases, you will have to keep a graft ready. If on table there is IVC infiltration, then better management is you have done everything, all controls are already in your hand. Best is to call the vascular surgeon, resect and put a graft. And if you find on table that the IVC is grossly infiltrated and sadly you don't have the graft ready, then it is injustice to the patient.
No, so actually patient, decided to, against the surgery. But what we had done is that we had already informed the cardiothoracic surgeon. He had come, seen it, and we had decided, planned out everything that how to go about.
Okay.
So I think the most important thing is involvement of, as you said very rightly, gastroenterologic, the thing, hepatobiliary surgeon as well as the cardiothoracic surgeon, and that only can give the better result, the best result.
Yeah, always. I mean, it's better to have a multi-surgeon surgery for these kind of cases.
Because we do such cases. I'm not talking of the Tata hospital or places where regularly such cases are coming, but otherwise they come we do very few cases like this. It is always multi-speciality is most important.
I agree. I mean, now Hinduja, I do these cases. So with a good team, the blood loss actually, if you do nicely, is just 300-400 ml.
Oh, wow. Good. So anything else we want to?
Question what I was asking and nobody answered was post-op after the histopathology. What these cases are T3B and we don't know N0 or N1, but in these cases, adjuvant immunotherapy, pembrolizumab is indicated.
Okay, okay. So
it
that was the most important, adjuvant immunotherapy.
for 1 year as an adjuvant therapy if there is no metastatic disease. That is shown. I don't remember the trial. 576 or 526. I don't know.
Oh, okay.
So it is Pembro given for up to 17 cycles, I think, up to 1 year.
So it improves the overall survival. Okay.
That rate is up to something like 40%.
Oh.
I'll need to check. Somebody who's putting messages down can check.
Good. So these are the 3 cases. Next time we will do upper tract TCC, and Ganesh, we can call the Vijay Patil.
Yeah, Vijay Patil is ready to come. For what, next time or uske next time?
हाँ बोलो ना. So to next time we have got upper tract TCC, 2 different cases.
So metastatic में बोला थे sir.
Okay, so we'll do accordingly. Huh?
Okay.
Yeah.
Good cases. Good, sir.
Okay.
Good night.
Luckily we got all the 3 good cases. We
Very
can
good
discuss.
case.
Yeah, right, right.
Yeah. Okay. Thank you. Good night, everyone.
Good night. Good night.
Good night.
Good night, sir.
Pankaj sir.
Right.
Gite sir. Good night.
Good night. Good night.
Good night, Hiren bhai. Good night, Gaurang Shah.
Yes. Bye. Bye,
sir.
Mahendra.
Bye. Good night, sir. Bye.
Hello, Swastik sir. Swastik sir. हेलो.
हेलो.
हाँ सर, एक्चुअली ना सर आप होस्ट हो गए हो तो
अच्छा,
ये
मुझे एंड
कैसे
करना पड़ेगा.
करोगे?
हाँ, एंड कर देता हूँ.
हाँ ना तो क्या रिकॉर्डिंग पूरा नाइट चलेगा.
ओके.
एंड कर दो सर. थैंक यू सर.